Hi, what about debridement in minimally invasive shaping? Do you have any idea? Do you know what are the risks? How can we manage and how can we have a predictable protocol if we want in the debridement, if we want to shape less? It's good to know the risk. It's good to know what we can have as a weapons in our hands in order to achieve a proper cleaning, even if we are shaping less the root canal system. We know in our daily practice we love to shape and clean and to do the chemomechanical action inside our root canal system, but we know that it's difficult to follow step by step our rotary files instruments with our needles and metal needles especially, and the risk is just to pack down debris or to collect and push debris in the anatomy that has not been shaped, like isthmus, fins, lateral canals, and so on. Try to imagine what can happen if we decide to reduce the taper of our preparation close to 0,3 or 0,4. We can just introduce our needle at the beginning of the anatomy, and our debris and maybe also pulp remnants, necrotic parts of the pulp and the bacteria can just remain there and impossible to be cleaned in a proper way. If we want to be successful in our in the ideal cleaning protocol, as operator, we have to satisfy few steps. So we have to know that the activation is important, that the good volume of irrigant also, the time of application of irrigants is extremely important. The method that the operator is using is important, and the chemistry of the irrigants, of course. So many things can describe and can push us and move our daily practice through and close to the success or also to the failure. Because try to imagine if we reduce the taper of our instrumentation, so the taper, the space that we shaped inside the canal, try to imagine the risk that we can take, and because the operator is the first one that is in trouble. The volume of irrigants that is introduced inside the anatomy is really lower, and the chemistry of irrigants is really complicated because the irrigants cannot be refreshed many times, and of course maybe we should need more time, and again we should need probably also more volume of irrigants if we want to achieve the same outcome that maybe we can achieve in 0,6, 0,7, 0,8 shape. So the operator is looking for a cleaning protocol, and the cleaning protocol doesn't exist in our conventional daily practice, so doesn't exist in the conventional shaping. Try to imagine if in minimally invasive, and this is a review that I wrote a few months ago, can demonstrate that the evidence in the literature is really low about cleaning protocols, because the time and volume factor are not so much considered in our daily from a clinical point of view. Of course, from a point of view of the research, laboratory outcomes and so on, we can have beautiful outcomes or we can find protocols. But in terms of cleaning and disinfection in our daily practice, a clinical protocol is missing. Is missing in conventional shaping. Try to imagine in minimal invasive shaping. I want to analyze with you the risk that we can maybe have to face if we shape less and we print just two beautiful white lines inside our X-rays, but two white lines or three white lines that are absolutely different from the reality, because our anatomy maybe is filled with debris, is filled with pulp remnants, necrotic pulp remnants, and bacteria. And we use bioceramic sealer. Has no sense, because if we don't do a proper disinfection, it will be impossible to achieve a good outcome. So everything is easy. It seems easy while we are shaping. Everything seems easy while we are filling the root canal system, but everything is more complicated if we want to keep and maintain the same armamentarium that we used until today for doing disinfection in small shaping, in small taper. Has no more sense. We have to change something. If not, the only risk will be to fill the fins, isthmus, lateral canals with debris that we produced with our instruments and files, because our needles are not able to follow all the steps of the shaping procedure, because our needles will remain always too much shorter compared to the working length that our rotary files achieved and obtained while they were shaping the root canal system. So if we don't have any risk, and if we want to really push down our irrigants in the apical region in a safe way, close the apical region, even if we shape less and we obtain a small taper, we have to change our protocols. We have to change our armamentarium. And this is the first step if we want to be successful in our daily practice. Conventional needles are no more able to do this, not due to the shape, but due to the material, due to the metal, because metal is good to penetrate just in straight anatomies and wide anatomies, because metal can just stop at the beginning of any curvatures. So if we have an anatomy that can, a curvature could be also interferences, can be represented by interferences, coronal interferences. So if we have a curvature, at the beginning of this curvature, we will see that our needles will be blocked. And so if we shape less, with debridement, we will have to face physical problems and chemical problems. Physically, because we are not able to penetrate with the needle inside the root canal system and follow the anatomy. And chemically, because our irrigants will be completely buffered, because it's impossible to refresh them in the apical region, but probably also in the middle of the root. And so we complicate our life for nothing. And the reason why, if we want to still remain on a conservative way and shape less, we have to change our needles. We have to change our armamentarium, keeping, of course, the same irrigants chemistry, but we have to change the way. We have to change the method. We need new protocols. We need new armamentarium. In 0.4 taper, if we pretend to achieve and clean with the conventional needles, it's a game over. It will be a disaster, because it has been demonstrated that it is absolutely impossible to achieve these areas with the needles if they are tapered they have a taper of 0.4, and we know that instead we should go there to 1 millimeter shorter, because we want to refresh our irrigants. This can happen in almost straight canal with a slight curvature. Try to imagine if we have a coronal curvature, we will stay there at the beginning of the curvature, or if we have a curvature at the middle or in the apical region, again, we will stop there without any chance to reach this area with our needles and irrigants. So curvatures must be maintained, but of course, must be crossed by our needles. If not, has no more sense to talk about minimally invasive shaping. It's better to go back. It's better to create a good taper. It's good to remove coronal interferences, because of course we want to introduce our irrigants in the apical regions. The reason why is so important to change the needle and go for plastic polymeric needles with this great technology like IrriFlex. And IrriFlex is the only one that has a close end, so safety, two lateral vents, with a lateral vents with the opportunity to have a good degrees and angulation of extrusion of our irrigants, in order to have a great turbulence inside the canal, and this turbulence can create debris extrusion, and we can have a great cleanness inside our anatomy. And the taper 04 is extremely important also for this. So IrriFlex is the only one needle that is made in polymer, and the polymer can follow the anatomy, not the metal. If you have any doubt, it's enough to see this video. In this video is evident how the metal needle is trying to change the irrigants in yellow, but is not able to penetrate in an already shaped 2504 anatomy. And it's able just to penetrate at the middle of a root. So we have a lot of irrigant that is still there, and the risk is to lead the first irrigant that we introduced there without any opportunity to refill it and change it. Instead, with the IrriFlex, we can follow the anatomy that we preserved. We were able to change irrigants, and in this way, we are sure that probably we will achieve our goal, a good debridement and disinfection while we are shaping the root canal system. Take a look to this extracted tooth. On this extracted tooth, that is a conventional extracted tooth, I opened access cavity. At the beginning, it was a minimally invasive access cavity. But of course, it has no sense if we have MB1 that needs more space to be achieved, because if not, we will do beautiful stripping. So I opened more of the access cavity with ultrasounds. I created a proper access cavity, and now I'm doing the first steps of my root canal treatment. So step-down technique, removal of interferences, but with files that are not so in a huge taper, but they are designed also for the glide path. And it's the first file that I introduced is a rotary file. And this rotary file immediately produced debris. And if I'm not able to follow this rotary file with my needles, of course I will stay just coronally. After I start my shaping, and the distal canal is almost straight, but instead the major root is a bit curved. I took my working length, but my metal needle in the major root are always blocked at the beginning of the curvature. In the distal root, instead, they can penetrate since the beginning in the right way. So they work. Instead, IrriFlex is the only one that can give you a repeatable protocol. So it's the only one needle that can work in both conditions, straight and curved. So it has no more sense to stay on metal. Now I am doing the glide path, and I want to follow the glide path with my needles. So I want to follow with IrriFlex, and I want to follow in order to release, leave irrigants where are needed, not coronally. Instead, with metal needle, I stay there, coronally, just coronally. So my endo debridement is just coronally. Has no sense. This is not endo. This is a trial. Instead, in the distal root with the metal needle, I can achieve the middle part of the root. With the IrriFlex, I can follow what my files designed for the glide path shaped. I can follow a 04 taper. I can follow a minimally invasive shaping. Instead, the metal needles must be forced a lot in order to achieve the middle of the root. And after that I change my irrigants, I have to activate my irrigants, and the best way would be a ultrasonic activation made in cordolet with the cordolet design, so with the thin tips 2002 that can penetrate as much as possible inside the canal. But if my metal needle find an old irrigant there, will activate continuously this old irrigant. Instead, I have to do after shipping, I have to follow my cleaning protocol, and I have to activate irrigant that is always new, is fresh. In this way, I have more opportunities to digest pulp debris, digest bacteria, do disinfection, and remove also remnants. It works also in the same way in the curved canal, of course. But take a look to a more complicated tooth. This tooth is a tooth with measure it with the two canals again, and they are probably confluent. I open my access cavity, I am doing the glide path, so I'm removing the interferences, the coronal interferences, and what I can do, what I can see is just one thing, that I'm able to penetrate with the rotary files just 3-4 millimeters, and I would like to follow my rotary files with metal needles and irrigants, because my goal is to remove since the beginning all the debris in order to do my chemiomechanical action. But what happened when I introduce a metal needle? That my metal needle is able just to engage the orifice. So we will release irrigants inside the access cavity. Instead, IrriFlex is able to penetrate 2-3 millimeters inside the anatomy and follow exactly what my shaping file did. Even if my shaping file did a small kiss to the anatomy and just printed the shaping, the coronal part, it's good to remove the debris there, because if not, the next files probably will push down debris and we can have a blockage, or at the end of our therapy we will have not a proper level of disinfection. So it's extremely important to follow the anatomy. It's extremely important to follow what we shaped, because just with IrriFlex we are able to remove debris. With metal needles, no. Metal needles are not designed for this, for doing this. They can be blocked there at the beginning of the root canal system. If we cut the tooth and we see the surface, now we are watching this tooth from MB1 and we are watching what is going on in MB2. They are confluent, there is an isthmus, I'm shaping MB2, and my goal is always to follow what I shaped with my irrigants in order to remove debris. Take a look to the metal needle. It's able to stay there and stop at the beginning of a curvature. Instead, with the IrriFlex, I can cross the curvature, I can achieve the apical region, I can remove immediately debris, and I can do my endo treatment in a proper way. So metal cannot do this. Instead, ultrasounds associated with IrriFlex can do a lot. But in case of extreme curvatures, of course, we have to change from ultrasound activation to sonic activation, and in this way we will follow exactly what is our goal. So the limitation of ultrasonic activation is extremely evident in case of deep curvature. But in conventional anatomies like this, I'm activating and changing the irrigants and then cleaning the isthmus from the debris. Exactly what was impossible for a metal needle, because metal needle can just deliver irrigant at the beginning of the curvature. And do not pretend to see your irrigants in the deepest part of the anatomy thanks to ultrasonic activation, because ultrasounds are not able to push down any kind of liquid. They just activate what they find around the tip. So this is the final clean of the isthmus achieved with the final rinse protocol. So we alternate cleaning, delivering of irrigants, and activation. But in reality, what happens? That if we have anatomy like this, is almost impossible to overshape this kind of canal because they are really long. What we can do is just try to keep and preserve and maintain the original anatomy. But if we do cleaning with conventional needles, we will stay where the green arrow is. If instead we move with IrriFlex, we will jump, we will elevate our cleanness in a proper way, because we will do in an easy way. We will deliver our irrigants, hypochlorite and DTA, where is needed, and not 4 millimeters shorter than our the working length. Try to imagine this kind of anatomies, how to achieve a proper irrigant refreshment in these situations, and they are not so uncommon anatomies. Uncommon anatomies are like this: small taper, really small taper, lot of coronal interferences, curvatures that are really coronally. And so, if we still want to use conventional needles, you will do your endo probably just coronally, shorter than 2 times than conventional working length. Instead, with the IrriFlex, you will be able to deliver irrigants everywhere. Everywhere is needed. So, has no more sense to stay on metal. Instead, makes a lot of sense, change our habits and change our armamentarium. And if we want and we pretend to shape less, my suggestion is just one. Put IrriFlex in your hands and you will change and you will elevate your end. From a live point of view, when we are cleaning with IrriFlex, of course, we can bend it, we can follow the files, we can, my suggestion is to introduce IrriFlex inside the root canal anatomy and start immediately with delivering irrigants before introducing inside the orifice. In this way, we will never smash or block the tip. And if you have a vital pulp, don't worry, because where your file shaped, exactly there, IrriFlex will be able to refresh the irrigant, remove remnants, remove blood, and do a deep disinfection. This is not so. This is a conventional shaping system, but in a difficult anatomy. So I'm doing my irrigation. I'm doing my debridement, and I'm delivering irrigants and refreshing irrigants. With IrriFlex, everything is easier. If we want to see also anatomies like that are confluent, we can do push-pull technique. Even if it's a small shaping anatomy, even if we do not overshape coronally the root canal system. So it's just IrriFlex, the only one that is able to do and follow the cleaning protocol in a proper way. And if we love to shape less, my suggestion is you have to change your habits. So we are talking about modern endodontics, where we are talking about minimal invasive endodontics. But if we want to stay minimal invasive, please, we have also to change our armamentarium for the cleaning protocol. If not, we will shape less, we will 3D fill the root canal system with also bioceramic sealer what you want in a single con technique, but in the middle we will leave a lot of debris, remnants, pulp, tissue, necrotic tissue, bacteria. No, we want to be successful in endodontics. The reason why, if we want to perform a modern endodontic treatment, we have to change and we have to purchase IrriFlex. IrriFlex should be connected to all your syringes. Guys, trust me, if you try IrriFlex, you will never go back. It's so easy, so predictable, and it's a really protocol that you can have in your hands. Has no more sense to stay on metal needles.